Okay, kusha una kabo, my name na Timu John Fuller, na me na the presenter for the Well Body Better Part Gentry program. We na Salomon the we don't learn book me where na me own book na primary one compared to the one they already present to now. The fumble and the non we already now we none of the get paid. Nobody they get paid. And Professor Lisk now in the present to we today. This man me not not even enough for say would I be here and try for introduce us. So what I go do, I will just not saying him when he starts, he go explain to now what I be. Leona self know from the horse's mouth. Today we deal in epilepsy in Sierra Leone, the clinical and socio-cultural aspect. And like I said, Professor Lisk, and the presenting today on the 3rd of March, 2024. And now the Well Body Better Part Gentry team, now then go day on hand for answer any questions we will get. My family, I always say this, and I get for see every session. We not then I for give personal advice. Not to say we not want help, but the reason we make we not do them now because we not get on a background, on a medical background, and if we not get that, they will make any advice. Something go happen to any of you now we then go all responsible. So now I make they give personal advice. So if anything they wrong with you personally, go see your doctor or your physician. Yeah, now generalized advice with the give I waiting at then sickness here, which are the issues they are waiting the cause how you can able to try for resolve them and all that kind of thing and the this kind of medicine for take out for manage them, when for go see doctor and then no more again. If we get any example similar like you and a family and similar no more similar, not to you would talk about directly. Okay. So as I've been saying before, we already do the program. Nobody know they get paid. We already do them voluntarily. Just for because we lack of mass alone, I make we do them. So they have a family. If anybody in the audience we get away for let this program reach people them not tongue eye, whether na radio or TV, we not they charge anybody anything. Anytime they ready, then just say no more. They are one, broadcast on a program go give them for free. But the only two one not go do because most of the people who don't get in touch so far, some of the radio station and TV and stuff like that, they will pay. Unfortunately, we're not going to give it time. Then part of that they expect to back say for pay. I think it's unfair. Me when I will call myself the junior now the team, I know how much I get paid. Me time alone, I know how much it costs. So I don't think say fair for what we get for pay again. However, if we begin get donation in future, yes, we no mind for pay because that they will try for do for make sure say una with people them no matter how side you get will benefit from this program. Okay. As I've been saying before, the program we put the recording on Facebook and YouTube. So anytime if you miss the program, feel free for go on Facebook or YouTube, go under the Well Body Better Part Gentry page, and you can feel free for watch. We get over, if I not lie, over 60 something versions, sessions they don't do, they all did it. You get from hypertension to, there are various stuff, them even sleep, sleep apnea and everything, people always struggle with sleep. There's a lot of programs that we do online. So please, I'll advise you now for on go the ball, so now share the link to people on our face, it will be beneficial for them as well. As I've been saying before, I go show now how for ask question. Most of them I go see this first picture on a tablet or on a phone. Most of them on a tablet and phone that they use. I know they use computer, the looks might be slightly different, but you go see these 3 dots now, yeah. So if you press that 3 dots, this thing will appear. If you press on the chat, you can chat to just like I did do on WhatsApp or on Facebook. If you are sending any question. But also if you want to ask question, I will ask you press that button there for raise your hand. I go see you and I'll come to you. However, if you're not able to do all of this, and you feel say you bold like me, put your hand up. If I see you, I'll come to you. If I not see you quick, I'm not come to you. You know what I mean? Say I dey ignore you, just missing I see I not see you, but I will make sure say I try to get everybody in question answered. Okay. However, we're going to be conscious of time, so we can kick off now. They can't over on to the parents. If you get any questions, feedback, or suggestion, we don't feel say we sabi all thing. Even me when they work within cybersecurity, I don't work for years now, I get experience, but means I sabi all thing constantly with the land. So they look for your feedback for tell we wait to for do, how for do thing for change. Please feel free for get in touch by email or WhatsApp. I will share the WhatsApp group link in a bit while the professor they present. So before I can mute everybody, and I will hand on now to Professor Lisk. We will take on through the session today. Thank you very much. Professor, you can share.
I've been on share. Let's share again.
Yes, sir.
Okay, I can start now.
Yes, sir.
Okay, so all man hear me. Good
Yes,
evening to all the colleagues them. I know say the audience not a doctor, they no more we get doctor them, or we get people that we not a doctor. So I get for try for explain the thing that way very medical so that even if you're not a medical person, you go able to understand. Then of course certain thing and they way maybe in the doctor they could be more of interest to. But on the whole, I know say all man go try to get something out of this program here. So today they talk about epilepsy. Epilepsy in a sick way, all man know but. In fact, every language get word for epilepsy. Na KRIO then you call them fix. They say na timini and they call them kachu. Na mende na bomboni. And get all language get young because na sick way it gets special and things them way can make people them get a kind of feeling about that sick day way can affect the people that we get them. So today we go try to see how this sick they affect Sierra Leoneans. So basically, all we will talk about na theory we don't see in our own clinic, not a theory we go read in a textbook. It's now our experience of the people that we don't see and the data that we don't collect and the paper that we don't publish on this year. So I will divide this talk in two different ways. First of all, the clinical landing and landing for do the doctor business. You go tell you what this epilepsy, how they classify most kind they, waiting at the cause them, how they show himself and how they treat them. Then I will also talk about what we call the socio-cultural part. Then the traditional belief in epilepsy, how people then they take people that will get epilepsy, how then they treat them. We talk about stigma. We will talk about epilepsy and women then, because we think to say women then they suffer more when they get epilepsy past how man they suffer. So first we get for say what is epilepsy. You get epilepsy, you get seizure. Okay, seizure na like convulsion. So convulsion, what can cause them? Now we can get abnormal current within the brain. We all brain a small current, they work with brain, where they make we able for talk, where they make we able for do all what we they do, please. So when that current they change or when something happen to that current, the current high too much, then it can sort of short circuit the brain. So whether they happen now, all kind of different things can happen, including epilepsy. So when you get seizure, no mean to say you get epilepsy, because you can get seizure or convulsion when you get acute illness then. In other words, like picking and so if they get high fever, you go see them go get convulsion. If they get certain infection, you go see them get convulsion. Even adults have certain things them, certain illnesses they will then get apart from infections or head injury can make them get this convulsion, yeah. What we know call an epilepsy at that stage there. The tail will begin calling epilepsy. Now, when they begin get this kind of seizure, so time and time again, and where the seizure now, it no relates to anything acute. So then with that seizure no more, it is campan them. So when you reach that stage, then now we call her epilepsy. So all over the world, about 50 million people get epilepsy. But most of them, 4 out of 5, they're in a developing country, particularly in Africa. They don't find out, say, the people that will get epilepsy in a damn place there, so like Africa, are 2 to 3 times more than the people that will get in Europe or America. When you look beyond kind patient the way they present now with clinic, because we get at the all that we look at the age, we find out say now more young people than this thing they affect. If I go to call it peak age, the age group when I we see more now between 16 and 20. Then as they get older, we see less. But again, you get to remember, say, the population of Salone, now young people and Fulham. So, in fact, any kind of thing they deal with, you go expect for FENA more per young people because now young people and they more than the population. But even though I don't say that, in developed countries, you will find out, say, that the same kind of pattern SFDC, the younger people, then they get them more. So until we find out, we will look the first 2,000 patients with the Canary clinic. The first thing we find out is that then they delay for go to clinic or for go see doctor. We find out say 20.7% then can get for wait 6 months after they get that first attack day before they go see doctor. Then another 43% can wait between 1 and 5 years. And 35.7% can wait after 5 years. When you put all the also together, you find out, say, the term way then they take from that first seizure day, for the term then go to clinic now almost 6 years. So just imagine that if somebody get attacked now, this 2024, now take 2030, now and then go see doctor. Let's imagine the time where all that don't take. So plenty thinking don't happen during that 10 day. In fact, some of them go don't die safe during that 10 day. So what to make epilepsy more common by our own kind of environment? First of all, we call back trauma. In other words, the kind of injury where baby then can get where then they bond them. Because we not get good obstetric practice system. So when they try to get them out, they can damage them brain sometimes, and then they can cause epilepsy later on. Then also you find out, say, they're not going to get oxygen now, plenty of their side and they will picking the bone. So with oxygen not there, then the brain can damage because of the lack of oxygen. Then again, picking can get febrile convulsion. Febrile convulsion not to epilepsy, but you get a kind of febrile convulsion where they can call complex febrile convulsion. That one day now way the convulsion can last long by the beginning, so up to 15 minutes. Then sometimes again it can begin at one part of the body instead of the one whole body together. So then beginning they will get that kind of convulsion they later on in life and get a chance for let them develop epilepsy. Then they don't find out again, say picking they get cerebral malaria. Then self can get epilepsy where they don't the big. Then meningitis, cysticercosis, then they are not talk much about that because we know they see that much in a salon. But then accidents. First time we get the war, we found out say a lot of the head injury where we see as a result of the war. But now most of the head injury we see are a result of accident, particularly bike accident, Okada. Every week somebody will come, we don't get Okada accident, we don't damage in brain. Then alcohol abuse again, I think very common in our own environment. So the way they can classify seizure, there are two main types. Focal and generalized. Focal seizure, that means to say this bad current will happen at the brain. And one side of the brain, one corner of the brain, no more it happen. So the way we can show itself by the patient, it can make the way not too bad, you know, in other words, now part of the patient no more go affected. Whilst with generalized seizure, then the bad current, they all over the brain. So when patients get that one, they now, when they get attacked now, they affect all the hand and the foot, the one whole body. So now the two main types down, the focal onset and the generalized onset seizure. Now I'll go for showing us some video of the different type of seizure. But before I show you the video, let's just explain the different type first so that when I see the video, you're going to understand. So the one way then at the top, what they call generalized tonic seizure. Now that one most people know as epilepsy, the fix. That one day where the patient go fall down a groan, he go, you know, he go flush in the mouth, he go bet in tongue, his hand go shake, his foot go shake, sometimes he go wet by himself. So that is the generalized tonic-clonic seizure that one day. Then you get what you call focal seizure. That day, now one part of the body no more, sometimes the hand or the foot no more, now inking the shake. And during that time, the way the patient they get a seizure, they is fully conscious. They know all what thing they happen to them. Then you get what you call a tonic seizure. Then in a way, the muscle then at the body, that's the loss then tone. In other words, they're not able for all up. So you go see the patient, if now aid, you go see aid that's for them. If now the one whole body get this thing, the one whole patient go just for them a groan. Then he grab back. Then call that the tonic seizure. So you get what they call myoclonic. Then the italic na electric, they shock the person. You go just see it jump. Either in hand or the one whole body go just jump. So then they call a myoclonic seizure. So you get another how they call absent seizure. Then in a picking more can get the one in there. The one in there, the patient, he go to do something they want to just stop. You see, begin look far. You know, they fall down a groan, you know, they shake, nothing. Then sometimes 5 seconds, 10 seconds, you see, can't to back. They begin do what they do. He follow up the same way we be left, now they continue back. They call that the absent seizure. Then the last one, where they call complex partial seizure or temporal lobe epilepsy. That one day again, the patient can they do thing, he don't know say they do them. He go come on here, he walk a go down the road, he don't know how we reach there. He go team up, he they take something at the table, he put them back. He take all that thing at the table, he put them back. Sometimes you go see they turn around, or sometimes you go see pulling close. You don't know all what they do, so you don't know. But you know they fall down a ground. So then they call them complex partial seizure. So now I go show you the video. We go show you all the different type of attack there, so that you go know. Myself, I go talk over the attack them so that you go understand clearly. The first one we see this bubble we wear the brown polo. Now for the for also luckily in Paddy Ketchum. But we go see how we then go now. We begin shake. In head they shake, in hand they shake, in foot they shake. So this is also not that generalized seizure. Now this is also most people they know for epilepsy where they can call fix. You see the bang bang head if in Paddy and up in there behind the head for the knock and the cement cone. So we go see say the seizure will stop now. Don't in Paddy they try for resuscitate them. They don't grab now. If they look at, but you can see say it days, you know, can't do it. It's still not sure it in the happen. Now this line I call myoclonic seizure. This one we wear green polo. If you're watching hand normal, you go see it in the happen. You see when hand jack, you see when hand jack back in Paddy, then jump, then afraid. But you know unconscious, you know exactly what in the happen. So they call this kind of seizure myoclonic seizure. It can affect the hand, it can affect the foot sometimes, or it can affect the one whole body. So this is now myoclonic seizure. Then the next one now, we talk now. Now this is now a tonic seizure. Where the man sit down, him neck just lost all in power, don't the edges for them. They call it a tonic seizure. Sometimes it can affect the one whole body where if not team up, the one whole person will just fall down a ground. This one also na focal motor. You see, in the reading book, like say nothing happen, but looking hand, a seizure they get na answer, but you know unconscious. And call it focal motor seizure. Okay. If you look this one also now, this bubble, then they send ball, not to this one, no, this one also where the brown, then they send ball to round. The one they see stop. You just see they look far. For a few seconds, you don't know what in the happen. Then they begin send the ball back. So then they call absent seizure. Then they call them petit mal seizure before. On this one also now, we then call psychomotor or temporal lobe. You just see the madness, they go round, around. If you talk to her now, where they go around, so you know the area what they say, you don't understand nothing. But all the same enough for them. So this also then call temporal lobe epilepsy, that's not the old classification. Now then they call focal with impaired awareness epilepsy. So as you don't know more, you don't come to back. On the next one, again, another example of this so-called temporal lobe or focal impaired awareness. In just the walking body front and back, they laugh. Not enough funny, just they laugh. But if you talk to them, you're not going to understand what they say, you're not going to hear what they say. So now the main type of attack then we can get, what they call epilepsy. But most people that have first one no more they know for epilepsy, but all in different ones, so now other type of epilepsy then. And apart from that, so plenty other epilepsy than they will not be able to talk about today. Okay. This now one with patient we na the same thing he present to we one mommy. It just presents say foot they shake. Again in full consciousness, na clinic they so in foot they shake. Instead na the focal motor seizure he gets. If fully conscious, if you talk to them, they answer you, but in foot test they shake no more. When we do investigation, we do a scan, we find out say that brain tumor now they get where they cause this attack there. So what are the cause for epilepsy now? So we see say the different age group then get different cause they make it more common. So the one the way just born and the small baby them, as will be mentioned, then bad injuries, injury to the brain where then they born, don't lack of oxygen, can make them get brain damage, we can make them get epilepsy. Then you get to call genetic cause. That now can then at the blood, then at the family line, where then can pass around to the picking them, don't the picking them go begin get epilepsy. They get infection as well. The way don't the big now, other thing then they like accident, drug use, drug abuse, infection, don't picking them begin get tumor again, tumors deep and picking not a big pussy no more. All the one and they self can lead on to epilepsy. Though they don't reach the older adult they now they begin get more tumors them. Then you got what you call degenerative disease them, that maybe where the brain don't they Then the whole things can happen, like then patient they will get dementia, so then self can get epilepsy. Then the blood vessel then at the brain again, as they get all the blood vessels, then they get disease. So enough blood not they reach there. So some of them can get stroke, then some of them can get bleeding. So all them things and they later on can go on for cause epilepsy, particularly the one they will all 65 or over. So I will just talk small bit about head injury because we see plenty tumors, car accident, we see too much head injury. So it depends on the kind of head injury we get, we will determine the risk for make you develop epilepsy. So the one the way they get to call penetrating head injury. Then if the accident will then get at the head, it go through the bone till it reach the brain. The one then they get a very high risk, up to 50% of them will develop epilepsy. Then again, we get to call the press skull fracture, where they whap you at the head, the bone they go inside. So we go inside now, it cause irritation by the brain, and then again can lead to epilepsy. Then if you get head injury where they cause bleeding inside the brain, or you get head injury where very prolonged, so that the patient they in coma for 2-3 days, all the one and then a very high risk for make the patient get epilepsy later on. The risk reduce if the head injury is a closed head injury. In other words, they knock you in your head, but you not go through the bone into the brain. So that one it can cause epilepsy, but the risk less past the first group that we will talk. So then people also will get head injury. They can develop epilepsy within 1 year of the head injury. But thinking the way it will take years, even up to 10 years after the head injury, before they will develop epilepsy. So this now patient will be seen, this have been just after the Rebel War, where in a chapter and chapter with cutlass, it go right through the skull and the brain, so it present to we with epilepsy. On this now one lady we will see in a potloco. You see, now this we call depressed fracture. When it be small, the mama and papa they fet, the papa take tick for whap the mommy balance, the tick whap the pikin and eat. So you can see what happen. If you didn't get the opportunity that time for let them lift this depressed fracture, not me for epilepsy, but by the time they see it don't too late. So now we talk about the seizure itself, the actual seizure where the person they get it fixed. They can divide that into 3 different stages. One we they call aura, then the seizure itself, the whole thing that happen where the seizure don't stop. So aura, now what way we can use, the medical people don't understand. It just means say you get a warning. In other words, you didn't know say this attack they come at you. If you're picking there, you go see the one go to the mama, then grip the mama. So the mommy can know say the attack they come. For adult, then different way they can get the aura. Some they can begin smell bad thing. Now they know and they smell bad thing and they don't say the attack they come. Some of them they go feel some funny feeling at them belly. Don't that feeling they go, they rise right up to the throat. Then they back now that thing they call aura. Wake happen before the epilepsy. So in other words, they can know say when they don't get this aura, the epilepsy they come. But then when the epilepsy can out, it can show itself in different way. So we don't show some of the way the patient they actually conscious, where they get the attack, then that's not the one the way they get the so-called focal epilepsy, where the bad current now one part pan the brain more day. But then you get other type of way this thing can show itself. The thing they call automatism, where now we been see that boy they go round and round and round like robot. So they call automatic behavior or automatism. Then the other one where they walking body forward and backward, and they gain automatism. So then they can come on also the worker go down the road, and now they reach there, then they back no automatism. In other words, then they do things automatically where they know what thing they do. Then the other one again we don't talk about where you don't see. Now the tonic-clonic attack, the myoclonic, the tonic seizure. We don't see all that deep on the video. So what happen after the attack don't do now? When the attack don't do now, the patient can complain sometimes that, sometimes he no know himself, outside day, and sometimes he can feel drowsy, he can feel sleepy. So he will go sleep 1 hour, 2 hours. Then he go tire or his body go hurt because when they get the attack there, now the muscle they contract, now work the muscle they work. So thinking the way the muscle then tire, the patient itself could tire. So all this can happen after. So the patient go able to tell you about this, but he not go able to tell you what happened during the time where he unconscious. So they ask patient them waiting at the thing that we can make the epilepsy camp on them. If you look the last two, you see say what you call sleep deprivation. Then when they will know they sleep enough, then they go night club, then they dance all night, then they put themselves at risk for make them get epilepsy. Don't stress. Of course, stress on the way you can avoid, on the way you're not able to avoid. But all man don't know say stress na way can cause epilepsy, give you more attack during the time where you're under stress. So how will they diagnose this epilepsy also? Plenty people like think to say, oh, na machine, if you put the patient on EEG machine, it will tell you say the patient get epilepsy. But no. The most important thing we they do for epi diagnosis na the history. In other words, the story. So part of the story, they way the patient himself could tell you. In other words, it could tell you if anything happened before the attack, like that, they get aura, so they will tell you whose kind way they feel before the attack all them. It will able to tell you what they happen where the attack don't left them. But during the attack, especially the one where they lost consciousness, they don't know themselves, they're not able to tell you nothing. So now make for that one and they will depend on witness system, people that we don't see what in the happen, for able to explain to the doctor there how the patient behaved during that time, the way the patient don't know himself. But even if we're not able to get witness, we get what we call silent witness. Thing and the way if you examine the patient, you're able to find them, it can give you a good and chance say that patient in a seizure get, an epilepsy get. So the first one are tongue biting. If they bite the side of the tongue, not to the front or the side of the tongue, they know say that patient in a seizure you get. Then if they dislocate their shoulder, particularly if all to the shoulder dislocate, that one they again a sign for sure say that seizures they get. Then sometimes they can actually fracture the vertebral column at the back because of the muscle contraction where they can get during the attack. It can make and fracture that bone so they can come around and get severe back pain where you x-ray them, you find out say they don't fracture the vertebrae. So if patients then come, nobody know been there where they get the attack, then get any of them signs there. So we call it silent witness. So this one patient who we see, you can see say he bets the side of his tongue to the front side. You can see all there, so the laceration we see. Okay. This now one man we see we been on the upline, he don't get plenty attack them. But now when after several years we reach down now we clinic now we see him. If you look in shoulder, you see say there is an angle. Normally all man shoulder round. You know they show any angle like how this they show. So when you see that, you know say na dislocation. In get an all to the side them, all to the side them. If by the time you reach to we, their shoulder they don't freeze. You're not able for moving hand again. How you see hand in the side so na so it dey. Because of the length of time where you don't get them dislocation in there. So what are the tests that we can do? Well, the most important test we can do now we call the EEG. EEG mean electroencephalogram. I should say most of it I don't hear you, but ECG, what they can do now your heart, when I electrocardiogram. Well, the EEG now the brain in brother of the ECG. So it measure the small current then at the brain. So if any abnormal current there, it will be able for pick them up. So we get different kind of EEG they can do. They can do routine ones, and they can make the patient not sleep good na net, because we know say when they don't sleep good na net, they put them at risk. So if we do the EEG that 10 day, they will be able to find more abnormality. We get what we can call video telemetry. Then you go for admit the patient, you fix the EEG, you put on with camera as well, so that when you get the attack, you will see the attack, then they're able to do the EEG at the same time. They get what we call intracranial EEG, and mainly for the one they will get forget operation. So if you look the EEG now, the abnormality we would look for now we can call spike or sharp wave. So this now the EEG lab, in fact, this now about 9 years ago, you don't much more sophisticated now, because we get 2 different machines now and a lot more equipment than we didn't get at the time. But you can see, say, basically all the wires so connect to the patient aid, a different part of the aid, so that it will give you information all over the brain. Then from there now, We also get a camera with a record the video, the patient as we go along. Then you get this light where they flash and front the patient. Because some kind of epilepsy there, if you look flashing light, it can bring on the epilepsy. Now make you know say, and then develop country them. When they can show some film them, they can tell you say, then they can show film them, we get flashing light. So the one they will know say they get then kind of epilepsy there, flashing light can bring, they know say they know for watch. So this is not the EEG lab we can use. So this is not the kind of recording we can get. If you look at the top, let's say the top 6 one, it look normal. You see that small zigzag pattern there, so now the brain wave then down the way they see. But then if you look down there, so you see then sharp chuk there, so okay, then chuk there, so now we call spikes. And that one they show say abnormal current there in the area then you see I'm back now, so. So the main thing for look now, where you get for look on this EEG that not to all the various beats there, not to all show the abnormality, and only some of them. So now I make them call this focal epilepsy, okay? So we mean to say that part of the brain normal this abnormal current depend. All the other side then quite normal, okay? But now if you look this other EEG now, this na patient will get generalized epilepsy. Up to this point here, so side the EEG change, all here so na normal EEG. Then we begin get the attack now. You begin get then you see them chuk there, so they call a spike and slow wave. But again, the thing you notice that all the different leads, they all get them. So now make them they call this generalized epilepsy because it is all over the brain, not to one side of the brain no more. So now that EEG they help for tell we. We help for tell we if this attack with the patient they get now focal onset, we will tell you if na generalized onset. Then we come to imaging now, what we call scans, okay? So whose time is necessary for those scan? A patient that we don't carry age, don't begin get seizure at that 10 day, you get for those scan. The one that we don't get history of accidents, head injury, you get for those scan. The one the way when you examine them, you find out say one part of the body weak, also abnormality there in the body, na one side, then you get for those scan on them. Who's there not necessary? Them picking the way they get the absent seizure, like that one where I show you where they throw away ball, throw away, they roll away, get the attack. The one they not necessary for do scan on them. But if you do scan at all, then the best scan way for do na MRI. But we not get plenty MRI. Now 2 MRI scan no more we get as alone. So and they're expensive. So plenty time there on a CT scan we can do, but MRI scan available for the one they were able to afford them because they give you more information past the CT scan. So this is a CT scan of a patient who get a brain tumor. This tumor is called meningioma. Like that one who have been shown now, we been can't to win our clinic where foot been the shake, and like this kind of tumor now been get in the head. So how will they treat them patient there so now? So all man will say drugs, yes. Without doubt, now drugs are the first thing where you will forget them patient there. But other ways they will then treat epilepsy. Then they even do operation, even surgery for do certain patients then will fulfill, you know, the criteria, then can give them surgical treatment. Then you get what we call vagus nerve stimulation. Then you get other kind of stimulation where you can put electrode inside the brain for stimulate certain areas, then for help with the epilepsy. Then not forget social support, because apart from the medicine, etc., you get for support the patient, them for help them through their normal life. So the general principle of treatment, first of all, you get for make sure say your diagnosis is correct. Then you get for look at the age and the gender of the patient. So patients they were old, you know, give them medicine, we go they make them sleep, then they forget things then. Also, woman they way get for born certain medicine and they way you know go and give them because it will affect the picking them. I will talk about that later. Then you get for look what you call comorbidity. Patient that we get other kinds sick, where you get for no bots, where they treat them. So the one they way them body big, they're obese, they're fat. Certain medicine and they will you know give them because some medicine and they where they give for epilepsy, where they make patient and put on weight. So you know and give them the medicine and they. The other medicine and they can make patient they lost weight. So you go prefer for getting the one in the. Don't patient that we get migraine. Migraine are a kind of headache. So if you get migraine or you get epilepsy back, you get medicine they we can treat all two together. So it's good for know if the patient gets any of them so-called comorbidities there. So, but in Lekuskai medicine you use, you get for look for side effect because you get for monitor the patient very carefully. Normally we can begin with one drug. Then if you no work, we will change them to another one drug. And then after that, now we will begin add 2 drug, 3 drug, even up to 4 drug. But the more drug you add, the less benefit you get, and of course, the more side effects you get. So now salon, now the drug then that's what they use mostly. Phenobarbital now we they use most of all. That one way the England and America sometimes them go laugh. Because phenobarbital 1912, now they begin use that medicine. Don't pass 100 years. But we still use them. Wait to make we use them. 1, it's cheap. 2, it retain at the body, so now 1 time for the no more they need for take them. 3, it's effective for different kind of seizure them. So it get a broad spectrum as we can call them in medicine. But what are the side effects? The main side effects that they cause a lot of drowsiness, and picking them, some taking and bugging them behavior. But the next second drug they use when I call levetiracetam, that is the most common drug they use worldwide. It's quite expensive, but we're lucky. We get to our NGO abroad where they help with this medicine. But we know they get enough, because if we get enough, really, we know for the use much phenobarbital again. But we use them quite a lot now because then they're able to send we reasonable quantity for what we use. Now, phenytoin, carbamazepine, in an of the medicine, and they sodium valproate, I'll talk small bit about that one day. Then, of course, lamotrigine, and then at this slide. Now, what to make a dimension sodium valproate? First of all, now the best drug down there for generalized seizure. But the problem with sodium valproate is that, particularly for women them where they born picking, it affect the picking them. What we call congenital malformation. They can get abnormal development in their brain, in their heart, in their kidney, different organs them. Up to 10% of the women the way they on sodium valproate, then go born picking we get them problem there. So although a good drug, we avoid them. In fact, I think see this drug sooner or later then we'll get for remove them from the market because they don't cause so much problem. Right now, as I talk, then get case them where they don't bring come against the drug company of women them way them picking affected. And apart from the one they way affected physically, it also they affect them development. In other words, the learning capacity, the way they talk and all that. So it gets a wide range of where they affect the picking them way the mammatic sodium valproate. So that medicine where we very be careful how we use them. So we don't treat patients that what you expect. So up to 70% of patients that we get epilepsy, we're able to control the epilepsy. You don't mean to say that they're not well, they're not well, but still, they're able to control the epilepsy. That one, the way you don't give the medicine and then they take them, because that know that, patient and get for they take the medicine, what we call adherence, and get for adhere to the treatment. Not to then go take today, then forget tomorrow, then take the next day, then forget next week. No, then get for take it regularly every day. So then they take the medicine regularly every day, they know they get control. It can be say, okay, the epilepsy tranga is. But it can also be say not to be epilepsy in the first place. Because thin and they will like epilepsy, we then call pseudo-seizure or non-epileptic attack, where if you look if you not on train, you go mean say epilepsy. Just last week, then send one patient kind of hospital, we've been in another hospital, we then say, don't they get this attack, epilepsy attack, they don't get phenobab, they don't get all kind of medicine, they get them. So they send a car up to in our hospital, we admit them. And one attack no more we get for look where the patient get, we know say not to epilepsy get. Eventually find out see the patient may get serious mental problem, then things will be in the worry. Within 2 or 3 days, all the attack they don't stop, we able for talk to them, Iwaka go. So for be very careful way they diagnose patient, the way they start patient and treatment, for be sure say the patient really get epilepsy. The one that we don't control, maybe 3 years, 4 years, then he ask say, well, I still get for the take the medicine or I can stop the medicine. Well, some patient and we could actually discontinue the medicine. You know, this you stop at one time or you go taper and small take over few months, you stop them. But the one and maybe most of them, up to 70%, they go continue without them no get more attack. But some of them go get attacked back again. So if you don't let them know, say, even though if you stop the medicine, they might go without attack, but they're not for surprise if attack happen maybe several years after when they stop the medicine. So again, you get for counsel patient, then, you know, they're not for drive, then they get attack, they're not for the claim letter. We own environment, woman and they cook na open fire. Again, for try for make them not do that, and for they put cold pot on top table. Then the one the way they use dangerous equipment, for tell them let them stop for do that. Then they're not for go inside bathtub, either then take kettle for wash or then take shower, and they're not for swim by themselves. So these are all the things that we get for the caution patient, them we don't make that diagnosis day. So upon all that, we find out the patient them we get epilepsy, then more likely for die, past patient we no get epilepsy. One of the reasons, of course, the thing where they cause the epilepsy can be the thing where can make them die quick. So if the patient get brain tumor, if he can get stroke, that will make the patient die quick, even though not all the epilepsy will kill him. But then, of course, patient then we get epilepsy, they're more prone for get accidents. So that accident, they have something they can cause death. Then you get what you call SUDEP, sudden unexpected death in epilepsy. Then patient there, then go well, then go sleep. Then not wake in the morning, then die when they sleep. First time, they think to say na attack, then go get, then suffocate or then choke, then die. But they don't find out, say, not all that not the main reason. They think to say certain nervous problem, they where they affect the heart, where the heart can stop, where to make them die. But till now, they don't know for sure which are the actual cause of SUDEP. But what they know is that patients them way get very poor control. They want the way then either they already take the medicine regularly or the medicine or they control the attack. They're more likely to get this SUDEP here, so past patient they will get very good control. They also know say patient that will get epilepsy, they're more liable to forget like depression and anxiety. So we've been doing a study, we do an Kenema in Freetown where we look for anxiety and depression per patient them. Unfortunately, the doctor who we all do this study, Dr. Tenema and Bio, unfortunately don't pass, God give him good road. So we find out, say, whether na Kenema or when a semi-rural or semi-urban or Freetown, or the percentage of patients that way they get this depression or anxiety now more or less the same, between 25 and 30%. And you can understand why. Because we could talk about that, we can for talk about the social aspects, you know, the things that they go through in terms of the epilepsy, the way people and they treat them, they make them depressed and make them very anxious. So this is now one of the things that with patients with epilepsy, then before they expect, before they look for. Okay, so I don't do the clinical side now. You can't talk about the socio-cultural aspect now. We all know, say, in our environment, when person get epilepsy, the first thing then they say na devil. They say na devil he get, or na witch. So that they make up to 90% of people that will get epilepsy. They know they bring them kind of clinic. They know they carry them go to hospital. So because of that, they know they get treatment. So now that's then called treatment gap. The percentage of patients that will get epilepsy, we know they get treatment. And that treatment gap, they can be up to 90% in some country then. Even in Sierra Leone, probably as much as 90%. Now, if you look at a patient with get epilepsy, when they get the attack, now tied in the time, then say na devil they see. So then time, if you look in wrist, you see say they see all the ligature marks then in wrist when in time when they get the attack them. Then this man, if you look in belly with the markham, we will see this man. We find out say this man, he been get epilepsy where he get aura. Remember I been mentioned say so aura can tell like say they get some funny feeling in your belly, we can rise up na your throat. Well, the Moriman way, they can go to and they say this belaya and they cause this epilepsy. So now he make this fine mark by belay for let stop the belay for cause the epilepsy. Of course, you know work. Then again, like he mark them again, like he give them the marks there so. Then go to call necklace, where then they give them picking or adult, then they tie them around the neck. And get different item na the necklace. Each one na for grab each devil. So the more item they get na the necklace, the more double they get. So this again are one of the ways them way then they show the ignorance about this sickness, so they call epilepsy. So we do this study pan school picking them and Dr. Desta Ali, where we say will been published. And we look at school picking them, we found out say 51% of picking them we get epilepsy, then they absent from school for at least 5 days every month. Then 90% they know they take part in games or sports. Because they think to say if they do that, they will get attack. Then 36% say the picking them, then party them and school picking them, they know they treat them fine. Then they mock them, and they humor them. So then it can reach a point where themselves can be afraid for go school. But then we will look at the teacher them, their knowledge, attitude, and practice. We find out say 16% of the teacher themselves believe say epilepsy in a devil business. 16%. 10% think to say epilepsy is transferable. They pass them from one person to the other. Some can say, for mass the patient in pit. If you mass in pit, you will catch the epilepsy. 14% of teachers think to say picking the way epilepsy not for go school. This na teacher them. Though 80% say they not go allow them speaking them for make them take part in sport. So you can see this what you will call unconscious bias. We'll be doing all that study, we'll be look at doctors, them, nurses, and CHO. We give them 10 different illnesses them, from malaria to chest infection, to diarrhea, to hypertension, to diabetes. We say let them rank them in order of the one them way they go like for treat and the one them way they no go like for treat. Pan all three the group of health workers then, the doctor, the nurse, the CHO, epilepsy and mental illness, then at the bottom two. So you can see, say, even for health workers, they get bias against epilepsy and mental disorders. Then. Now, we look at stigma. What is stigma? Stigma, now when you get something, people they look down on you for that thing they will get, or they try to avoid you. Then get two kinds of stigma. One we then call perceived stigma. Now what do you believe? You think to say, then they stigmatize you. In other words, if you work inside a room, mid inside the room, I deal with me party them. I turn to the party, I begin to talk secret to you automatically want and think to say, now we can inside the room, now I make with the talk. And you then the talk about. We are calling the perceived stigma. Then you get enacted stigma, then now the one way doubt not the. We wake inside the room, all man grab the gun do. We sit on a bench, all man push. So then enacted stigma. So we look at the stigma per we patients them. We just published and they just in November last month. And we find out say for perceived stigma, almost 54% of Sierra Leoneans then get perceived stigma. And we'll compare with other countries in Africa, particularly Ethiopia, where they don't do a lot of studies. Now around that same number they get. But in some areas they even get more. Some side they get up to 81%, 71% stigma. So perceived stigma is something where it all over the African continent. And then you look at enacted stigma. In fact, even worse, 80% of the patients then don't experience enacted stigma. We don't know for sure say people then behave badly to them because of the epilepsy they get. And we'll compare to in neighbor Nigeria, we see say themselves they get high levels, 67.7, 91.9. But in a nothing to say this stigma na Africa no more ideal. Even in Europe and America, patients that will get epilepsy, they get stigma. But no more, more subtle, obvious like the way we do. But if you look at the literature, you will find out say stigma is there all over. But it was the less knowledge they know about the illness. The thing that we can make patient complain of stigma, now they were so. Age. If I say patient that we don't big, then they will all 51 year, more 51 or more, you find say that they complain of less stigma. Because we think say they don't develop ways for cope with epilepsy so that they only complain better again. Then woman them again, then they get more stigma. The one that we not married, then they get more stigma. The one that we learn plenty book, then they complain less of stigma again because they're able for cope. Whilst the one that we not learn book, then they get more stigma. The one that we they get frequent attack. If they get more than 2 attacks per month, then you get more likely for make you get more stigma than the one that way they get fewer attack. The one that way the epilepsy don't tip on them, they don't get epilepsy for a long time, then they complain of more stigma. Then the one that we don't get bones where they shown at them body, either the hand or their face. They will tell you, say, then they stigmatize them because of their scars, then they don't get to the body. So lastly, now we will talk about epilepsy women. Then. So we look at 214 women that we don't get epilepsy, different age group, average 29. So we do an all the provinces, them 45 districts, so not of Freetown no more, all over the country. So we come out with a lot of things, but I will only just share some of the important things then. First of all, land under this slide, we find out, say, more than half of them not go school at all. But then when we look at the born picking business, we find out, say, almost half of them, they're not born. They not get picking at all. The one that we born, most of them, 95% say they need people there for help them for look after them picking. But for that 95%, they will say they need people there for help them. Less than half, only 45%, actually they get possibly they help them. So somehow they get for manage by themselves. They'll look at their daily life. Up to 62% say they will go market by themselves and they can cook. But how do they cook? Then they cook now open fire, either coal pot or firewood. And we don't see lots of patients that we don't get seizure, them fall down at the fire, them burn them face, severe burns them. So they try for tell them, say, if you want for cook, put the coal pot on top table, so that if you want for them, you go for down at burn. But the interesting thing is that 31% of the women then feel to say them company woman, they know they respect them. Whilst now only 23% think to say man, they know they respect them. But from the manual side, quite a few of the women then complain, say, man, then they rape them even during the terror, then they get the attack, which is quite remarkable. So look at their livelihood. Now, only 28% of them say they get some kind of work. Those kind of work they get, either they're a petty trader or subsistence farmer, or then they do, nurse work. But all of them say if they not been get this epilepsy, so when they go school, then if for do other kind of work like teaching or nursing work. Again, 39% say they're able to spend money for buy the medicine themselves, or the other one they say pass them get for beg or the people that help them with the medicine. So for summarize, we find out say women that will get epilepsy, they're less likely for married. Women that will get epilepsy, they're less likely for get bikini. Women that will get epilepsy, then less likely for go school, and they're less likely for get work. So we feel to say really, epilepsy they affect women them more possibly they affect man them. So what we don't do pan the epilepsy program? So the time we get a lot of funding will be employ what we call epilepsy support workers. These are social workers them who can send go to school, na church, na mosque, na workplace for who explain to people them what the epilepsy be, encourage them say if they know anybody will get this sick here, so let them bring them kind of clinic them. They will also engage the traditional healers them. We never pull braid that they mouth, but still we tell and say if the many people there. So first of all, not use any dangerous method like for cut them or for put their mobile pot with boiled water and leaf and all thing way then can injure themselves. If in assisted they already respond in a send the let them kind of clinic. They don't get plenty workshop there who we don't call teachers them, women group them, and of course health workers them. For health workers, they will don't train over 2,000-3,000 health workers them on epilepsy. We also don't train mental health nurses them, where we use for one some of the clinics. Then you use radio and TV program, jingles, posters, etc. So what are the challenges they will get? First of all, the ministry will not prioritize epilepsy. Then just publish the non-communicable disease strategic plan. And they not talk much about epilepsy at all. It's all hypertension, diabetes, and strokes, etc. They don't put epilepsy there. We found out say almost all the medication who they use, we get for source them outside the country, where they use NGOs that were they outside in England, America, where they help with the medicine system. Again, we don't get enough manpower. We don't get enough trained neurologists them. So they do what we call task shifting. So they train not only doctors, but even non-doctors, CHOs them, on the diagnosis and treatment of epilepsy. Then CHOs they are when I call community health officers them. And then they run a lot of clinics them up in the province system. We also they use the mental health nurses them for 1 week clinic them and for take care of the patients them. Again, we lack funding for continue for the give this training and updates to both health workers then and also to other groups of people then. So remember I will be start, we talk say it take up to 6 years when the day patient get the first attack to the tail then they can clinic. So between the tail we start we clinics them, and about 3 years afterwards, from 2012 to 2015, we monitor this delay. So we find out that the delay we don't cut and down from 6 years to 4.5 years. And we not do any for a long time, but some preliminary data will get show say it don't go down to 3 years. So really the intervention they do, obviously it work. I mean to say more people that know now about epilepsy. We clinics in full. We get clinic once a week. We get over 100 patients them at any one time. So the clinics are full. So it mean to say the word they go around about epilepsy say this is also not a double for bringing a gun clinic. So there are people that we don't involve for we program them in in terms of help with funding, manpower, and also I thank them all for the input we don't give into the epilepsy program. I also thank Dr. Joseph Kamara, we also help with the slides where we look today. So I thank you all for your attention and I'm ready for take any question then if you get any. Thank you very much. Dr. Fulham, Mr. Fulham, done.
Thank you very much, sir. Thank you.
Yes, sir.
For some reason, somebody take the host away from me. So it's been difficult for that, but I don't get them back.
Okay.
Thank you very, very much for the presentation, sir. The place here no more. Fix as until we all know, as until we all grow up, they see various people in the get them. And to be honest, some of what over and maybe don't they around medical stuff, don't learn a little bit. But for me, some of the things that we explain today, they say they get different types of may not be know about that. And I'm sure because of people back home don't know much about it here. And so that session is also very good for open we are, we see exactly, waiting they cause this thing, how for manage them, and try for break down the barriers them and stigma with people will maybe they ask what's that stigma. Stigma means like we with the looks of body they point finger upon. We not really understand what happen with the person based on waiting somebody don't tell we or maybe granny and grandpa, certain day, within we own culture, which is it's not bad. And they say bad. But then there's some story they when they can pass from generation to generation and pass on to we have not fully understand, and also in we culture, we find it difficult to ask questions. The moment you begin ask questions, they say this begin too fit, because we're not can ask questions, then we can get a wrong idea of the entire. So, like we Prof say no more, they told they go school and go say no mass, but then Pete, not go near them, not touch them, that thing they can now with the free self for play with them because people are just normal picking like a but we don't stigmatize a lot of people. We don't turn a blind eye. We don't avoid people that are good people and just because of the sickness we didn't get. But that's actually also the help people. Let we understand, let we learn. So at least we be able to manage them here And then, if somebody gets in our family, at least we don't understand now how, for management here. But also for we believe, we're not a discouraged person, say, do traditional. What we always advise is before you go traditional, try for seek medical advice first. But if the traditional you want to go, at least you don't understand the entire. So at least before you go there, you don't get what we can call informed. You don't get informed decision. You don't get in the information where you need for you make that decision where you need for make. If you decide for go the traditional way, you're gonna say no to because medical people enable help out. Yeah, Auntie Nafi?
Yes, thank you so much. Professor Lisk, thank you so much for the presentation. Very informative. I get two questions, sir. The first one, you mentioned about aura. Is there a timing between the aura and the time where the seizures they begin? That's one question. And then the next one is, I don't know what are the advice you will give with somebody there around, like a relative or friend, somebody, a friend or relative, they get generalized seizure. What thing for do for them at that moment when they get it fit? Okay, some people they say, well, for press and don't let they fit so, not fine level. Then they restrain the person. I don't know what thing are the right one for do for the person. Thank you.
Okay. So the first question, which are the interval between the aura and the actual seizure itself, can be seconds. It's very short. By the time the patient they get the aura, the seizure don't come. As I say, when picking and they get, I go see one go to a mama. By the time they reach to a mama, matter of seconds, he begin get the attack. So the aura they occur almost immediately before the seizure start. Then first aid measures we can do if somebody they get attacked. First of all, let's talk with you not for do. We all man they do that now for put something in mouth. Because we will say, oh, now for put spoon in mouth, oh, now for put spatula, they put nothing at the patient in mouth. You turn on inside, put on at the semi-prone position, turn on inside, make sure say vomit or inhaling vomit, and make sure say it in an environment where go harm himself. In other words, till we near we dangerous if you get near fire or near any side anything where sharp or we go harm him, make sure say pull all anything in the LFM. This is yourself doesn't take long. As I say, few seconds, maybe up to a minute, 1 or 2 minutes, you don't stop. So you do more harm if you try for restrain the patient than just left the patient go to a seizure and then it will come around. So not put nothing in mouth. Please, and then the message down the way, you won't believe even doctors, nurses, they still do that. And we still say an ISO. So it's very important for make people know say for put nothing in a patient in mouth when they get seizure.
Yeah, so the second part where Auntie Nafi asked as well. So when the person they in that state, what are the best advice for you get for Olam, restrict time, or just try for make sure somebody don't have yourself? How you go do?
None of that I talk so. The restrict time, you just they left them. You left them, make sure say if they jam in aid, like whether man put in hand under the bikini, the padding aid for letting or jam them. If you get pillow or sponge or whatever, you can do that. And then you left and let it do. They restrain them. You should not restrain because the seizure it lasts a very short time. So after that, the patient they come around. So if you want to try for restrain them, like how them do that one where I show it and try for time and that not to the way for good. So just left them, let it go to a seizure, and then after that, it will come out.
Okay. Another question I will ask. Anybody, let me just check if anybody else want to ask questions, if anything in the chat before I go off on one. Just be a moment, please. Okay. Yeah, the question I'll ask is now all epilepsy, that somebody go lose consciousness. They all, is there any one of them way it will happen and the person know waiting to happen around them?
Yes, but if you remember the video, you see say there are two types they will see. One double bowing and be the jump. We will influence them in the around them.
Yeah.
If been quite conscious, you know exactly what they happen to them. Oh. Okay. Then the other one will be the reading book. Then he left his hand on top the table, you see the hand they shake. And also that woman who was showing her when we on patient going foot they shake. A seizure then they get so, but they are conscious. But then they call them focal seizure. Okay. If focal means to say now just one part of the brain, no more the abnormality there. So they have not, so the way they show itself now, only part of the body they show itself pan. But when you get a generalized seizure where you affect the one whole body, then you know they know yourself at all, you know the conscious while they get the attack them.
Okay, thank
so
you.
So it depends on the type of attack where they get.
Thank you. Another thing I want to ask, this is not something for do with ethical stuff. This could be a challenge for the people in a salon, but really they need for your ladies. Would you go advise a young person, well, a patient, we get for go school or maybe they apply for work? You feel say, for example, if they apply for work, if or tell an employer say, you know, in a patient, you go advise that. And also what you go advise employers them for do, for support a staff, if a staff declare say, then a patient.
Well, first of all, it depends on the kind of work. Okay. I mean, if you go apply for work, you know, for be electrician, I'm not going to say that they go advisable. If somebody want for apply for that work, they are nothing to say that person they go and disclose say he get epilepsy. Even though not to your own benefit for make it do that because you know for do that kind of job there. So it's good, as you have say, in our own environment, we are not mature enough. So if you be honest to yourself, you defend work, you know so you can get attack, and then you tell your employer, say, yes, I get epilepsy, almost certainly that employer, they go biased against giving you that job. So you go find out, say, a lot of people then go hold that information there. But then, of course, if they can't get attacked now at the work, why is they don't get the work, then it's clear for all to see. And that then the employer can say, well, if they may get medical form with them fill before they not declare them, then of course, then in a breach. So if everything is, you know, as it should be, if we do it in sophistication with the rich and then developed countries, then yes, you should declare that you have epilepsy. But unfortunately, in our own kind of environment where we did, it's many times now to the patient the advantage not for making that declaration there because they know say if they do that, it will count against them. So it's really, there's a judgment call and then get for decide.
Thank you very much, sir. The reason we Amadou, I can't you. The reason we can ask him as you rightly point out is that the kind of session as well where we get for try for educate people. So some of the people in the audience at the moment, maybe they run companies them, or maybe in future they might be running companies. So if we not they try for educate them for let them understand, say, as per employer, you know, in your responsibility, you get a duty of care for sure to your employee, you know, to your employee, but also make them in a way, not make you work in environment, you know, that toxic that somebody for free for tell you say it gets something like this, not to a death sentence. Basically, the person can live a normal life. It's just that once in a while, he might get an episode. If he does, we'll able to put structure in place for support him. Because now, for example, if somebody get in kind of thing, you get a work body, somebody will go be a body where they go don't train for understand which now the triggers them and stuff like that. So if something happen, that person then I go make sure say it there around for make sure say you be okay. Yeah, Amadou. Now, unmute yourself first, sir. How are you?
Yeah, okay. Yeah,
welcome,
good evening,
sir.
everyone.
Yeah, good evening.
Yeah, really, this thing don't enlighten me today because now see why be the follow up. Really, I be don't in a relationship with somebody where be they get an attack ready. And also, they say, this, I want to ask, let's go straight to the point. I want to ask if this thing are from through the DNA, if you possibly get them, where you born that picking day, is this stand a chance for it gets this sickness? Two, I again say back again, because one nurse talk say, the only tell we possibly get them back, like where woman get belly, where young, where now you first born. Yeah, you man from the one we get belly, say, he born that picking day, you not get sex with that bandy, you not get sex with him. It they lead to that. He said three game back again, say, we belly woman, the pa belly, elect for charm ice block. They say that they give seizure to picking where they lead students in a day. So all along, I will try forget program like this where we will ask them question that. So doc, but I want to know if them thing are like if really not true. And how we prevent that.
Yes, doc. Over to you, Prof.
Well, I you say $7 something today. So me $7 something today because really I know anybody want to need it before. But I should say the one for the charm eyes and the one for, say, the woman, you know, from conceived, born in August sex, is likely for born peculiar epilepsy. That one is not true. But the one way it talk way, say if somebody get epilepsy, if he can pass her on to picking them, well, it depends on the type of epilepsy. Because if you get epilepsy now, because you get accidents, we make you, you know, you get brain injury, now can cause you epilepsy. That one they not go pass them on to you picking because now circumstances cause that accident they will make you get the epilepsy. But certain type of epilepsy, then they will, it are the genes, you can pass on to you picking them. But a lot of the epilepsy they see in epilepsy where they result from what we call acquired causes. In the way you they catch, you know, like infection, like stroke, head injury, the one and then a theory happen to you by chance. So that one and then you not go able for pass them on to you picking them because you know the fact that it happened to you know mean to say get for happen to you picking them. But you get a group of patients that will get a genetic tendency for get epilepsy. So if they get that genes there, they can pass them to them picking and the picking themselves could get epilepsy.
Thank you very much, sir. David Silla, they come to you in a bit. We get a few questions them now the chat. Somebody they ask say how long does the post-ictal period last for each type?
Yes. The post-ictal period, it can be a few minutes, it can last sometimes for hours. And as I say, some people then go sleep. They go sleep for maybe 1-2 hours before they come around back and be normal. Whilst with some again, they can get them within 10 minutes, 50 minutes, they're back to normal. So it depends, but it varies, you know, from a few minutes to several hours.
Okay. Something that when myself will ask, you know, somebody don't ask them. Any of them one day can lead to death?
Yes, remember what they talk about the chances of people with epilepsy get a higher death rate than normal people then. And I mentioned two things. One, I mentioned waiting and called SUDEP, that's sudden unexpected death in epilepsy, where the person go well, he go sleep, then he die in his sleep. That one day it can happen a lot, and then people who get epilepsy where they don't get good control, they don't take the medicine properly. Then you get again accidents. People who get epilepsy, then prone to accidents, especially the one where they take advice, then go drive motor car or go ride bike. So they can get accident as a result of the fact that they get seizures whilst then they do their activities, and they also again swim and go swim and drown. So there are a lot of things and the way they can do, we can make them get accident, we can make them die. So epilepsy, yes, you know, not to say the epilepsy is if they kill you directly, but it can, because you get a kind of epilepsy that they call status epilepticus. And they will get a very long attack. Normally, I've been the ten say attack will last for a few seconds, maybe to 1 or 2 minutes. But then you can get epilepsy or epileptic attack which lasts for hours and hours. They just go on, the patient just defeat. Then they get a very high mortality rate, up to 20% mortality rate. So yes, epilepsy can cause death in various ways then.
Okay. Thank you very much. David Abeg, David Silla, the country Abeg. You say something that we have been one ask as well, because I get few, well, you know, we don't see how I can do stuff. Normally, when there's a topic, I can get notes what I cannot put on the side. Because we don't hear, you know, the session before. The question I want to ask is, you don't mention some activities where you go advise for let people know, you know, is there more activities than they will on the individual for decide? Because say, for example, driving, you know, as you don't point them out, it's not advisable for letting somebody. Is it advisable? Well, it's not advisable or the person not for do them at all.
Oh, no,
it's certain activities, say maybe swimming. Is there any more where people the way they suffer from NTR for try for avoid for their own safety, not so just for people for others, but their own safety? Is there any more activities where you go advise?
Well, I talk about heights, you know, like climb ladder. So if you want to be painter, not to walk down the way for do if you get epilepsy. So in terms of driving, in most countries, them is statutory, not to the patient, not to the person they make that decision. By law, if you get epilepsy, you're not supposed to drive.
Okay.
And you get for them free for a particular time. Some country then they will say 6 months, some country in 1 year, some country in 2 years. We not forget non-attack at all on treatment before they can give you license back. So some of the activities there, so it's actually dictated by law. And some of them now, now by yourself, you will see waiting good for you and waiting not good for you. And the occupation is very important again. A lot of occupation deal with patient no go where they not for do because of the danger we involved. I don't call electrician, one, and painter, if you get for the claim heights, two. So quite a few things, and they way by common sense, if you no say that day, for do them, because if you get an attack, it will cause injury.
Okay, another thing. Is it possible say somebody can get any of them type there and you don't know?
Yes, it's quite possible. Well, they can say something to them, but they're not saying epilepsy. In fact, a lot of people then different type seizures also I show. A lot of people then content today and they know say really that is epilepsy. Because what people can think of epilepsy, now the way the phone go on, you shake, you feel like more. So all the other different types, yeah, so people are not really consider as an epilepsy. But then the one way they really know, now this is what we call absence, where I say that picking can get, where they can just, they can just days, then they do something and they stop, then begin stare for 10, 15 seconds, and come back to. Then the picking they no say they get them at all. A possibly they look them now and go observe, say that they happen to them. So yes, you can get some kind of epilepsy where you self no say they get them.
See? They learn more. Somebody they ask as well, see, maybe this might be to the extent, but I get for asking still. If you got advice for or at what point you got advice for let somebody wear safety gear, for example, helmet and stuff, when they suffer from this.
Yeah, in fact, I don't I reduce me talk so much that I be actually get a slide of one bubble where they get this atonic seizures, where they for them, we get a protective helmet, where we make for them where they wear. And I mean part of my slide, but I mean get for remove them where they try to keep within the time. Yes, mainly the way they get this so-called atonic seizure. For that atonic seizure, you go to work a day, just for them are gone. Just like that. Anyway, for them going, you can hit your head. So picking them when they get that tonic seizure, then we can always advise that they wear a helmet, styrofoam helmet, not to like motorcycle helmet, then lightweight styrofoam helmet for protect their head in case they get attacked. Yes, a good question that one day.
Okay. Right, let's see the other question. So somebody they ask, waiting the medical community they do not salon. Waiting now the Sierra Leone medical community then position on changing some of the contributing factors. For example, Okada, head injuries, back injuries, and need for oxygen facility, and the limited medicines for epilepsy in Sierra Leone.
Well, that one day, a lot of waiting you talk so that they not they within so much the medical community as they deal with the ministry of health. I mean, we don't make we always they make petition to the minister about medication, about various aspects of epilepsy. But as I say, it's unfortunate that the ministry not take epilepsy seriously. They don't. So we can only do what we can. We can only advise. But when it comes to certain things that then get for do, certain things that need laws with regards to CADA, etc. It's a law say that for wear helmet, but they're not they wear helmet. The police then are treated and they see them they pass. They know they stop them. So we can't do anything about that. I mean, we can only make them know say it's a dangerous thing. But if the law enforcers themselves know they actually do their job, then it's very difficult for we.
So is this a case of maybe education, awareness, and sensitization, that kind of thing? Is it lack of knowledge why make this taken and serious? Because I need just talk about just the Okada riders them. I'm even talking about even the passengers them. Because this something happen, really for them, there's no discrimination about who side or who they for them. So is this something say maybe the powers there be maybe the need for be educated maybe for them to understand the dangers of this thing?
I think everybody knows that there is a danger. All my way go now, Okada knows that there is a danger. But it's a question of attitude and availability. First of all, very few Okada now go get 2 helmets. First of all, the man they ride the Okada himself no get helmet before I say for get helmet for the passenger. So it's just that these things are not enforced. There was a time when Okada been just kind of this country, each Okada they get 2 helmets. We come then give the other one. Then of course the man go say they bug the some man go say, well, no, me don't know that over this helmet, me know they wear and I'm head. So many, reasons, and some of them genuine reasons why they don't go wear the helmet. But of course the bottom line is that if you know wear your helmet, you risk head injury. And we see that all the time. So it's a big problem.
Okay, let's see. I mean, get a few more questions there. Let's see. We'd almost finish. I just want to make sure say Umu say ask me a question, but I may not see I need to Umu. Okay. Okay, Umu say I would like to know if excitement or anger can trigger epilepsy seizure.
Yes, it can. Just like stress can, also excitement, anger. Yeah, definitely. So, emotional events can trigger a seizure. Yes.
Okay. For Ramatu Kroma, I would say, we don't touch on this already about the employer and employee responsibility. I think it's a two-way thing. The employer get for make sure see the environment, conducive for let the employee able declare. See, yes, he gets a medical condition, not just for epilepsy, but other medical conditions. Now, like we Prof don't say before, the way also we need so now, there's certain statutory responsibility both on the employer and the employee. For make sure the employer make the environment that somebody feel free for able to see waiting an issue, and as long as standing not going to forget nothing for affect in role way they play, therefore find the job without discrimination. But on the other hand as well, you the employee as well get that responsibility for tell your employer, because if something go wrong and you not tell them, something go wrong later on, it's on you. But as alone, I guess we just get time for go. As you see, a few years ago, me saying I'm in Bobo, now me saying a big man. And there's a lot of things in they will be they happen when me be young and it still they happen. And they hope say, as Prof don't say I'm as well, then sickness are not all evident that you go see somebody Some of we maybe we don't suffer from them here, we'll never even know say we get them. Only now when they begin learning say we get them. Yeah, Fauzia. Hold on for 1 minute. I got to reclaim the host, or else I'm not able to unmute you. Fauzia?
It's me? Oh, thank you. Professor,
yes, with you, ma. Go ahead, ma.
Okay. Professor Lisk, thank you very much for this very informative presentation where I enjoy. But I think one thing where I really take from this is the awareness where they don't raise in Sierra Leone. And from I think the percentage where you give was that about 60% of people are now aware of epilepsy. We're thinking cause them, how they, how to recognize them and all that. Because before me left Salone, I was a doctor in outpatients in Connaught Hospital. Now they bring one young girl. She was about 18 years old. They don't get these fits. Then a fits, then they call them. They don't get these fits for years. Nobody not ever bring to hospital. The only reason why it turned up now outpatients that day was because they get this grandma general tonic-clonic fits, and it bet in tongue. It bet in tongue to the point that the tongue cut in half. So maybe they bleed a lot, the tongue just ended. And that's not the only reason we make them bring Franca hospital. So we begin concentrate now for sew this tongue up, make sure say we suture them, make at least, go cut come out. And before we begin remember now about how for treat, for refer them and treat and everything. Unfortunately, fortunately I would say in this part of the world, now in England, all this thing is streamlined. There's, you know, people that are aware from where they're small, from where they're begin, they don't begin for take medication. So sometimes they, for if you make you see possibly get seizures, it's younger. First, you go get an os, then the brain come. You know, or sometimes you stop for taking medicine, he gets a seizure and os, then brain come. So I just want to make that comment. I'm really happy about the awareness, and I'm sure it's going to increase. It will increase as time they go on. So thank you very much for the presentation.
Thank you very much for your contribution. I get Shitu Rose. He say he just ain't no mind for sharing experience and just done diagnose with epilepsy. I will try for ask and for lay on mute. Shitu?
Yeah, hi.
How are you? Thank you very much.
I'm fine, thanks. Yeah, thank you. Thank you very much for the this very informative session. Yes, and just to add with the lady we talked before me say, I'm so glad that it gets more awareness now, because I started getting seizures. I started with petit mal, and it was in my teens in Sierra Leone, and nobody know what I mean, you know. And at the time, the only conclusion they could come to was I was possessed, right, by the demon. So it was some spiritual thing linked to it. While I go to England, actually, Dr. Lisk, now you diagnosed me in a Royal Free Hospital. And that's when I started getting my treatment. And so I have gone through different processes of epilepsy. What I started with was petit mal, and I've had a few. And the reason why I was even taken to hospital in the UK was actually I got a grand mal, basically, and then the ambulance, they had to take me and I was diagnosed. But it was really unheard of in my time. That was in the 90s, early 90s in Sierra Leone. And yeah, and I'm even on medication right now, but I just want to share that even though I'm a epilepsy survivor, I get periods of time when I have no seizures, and there are times when I do, and it's all, you just have to be aware of your stress level. There's so many things I actually have to watch out for, but I do drive. Here I live in the States in Minnesota, and basically you have to be seizure free for 3 months before you can have a license, or before you can get on the road to drive. And I haven't had a seizure in a long time. It's great for the people around you to actually be aware of your situation or how to deal with it. My husband, he had to really learn about seizure management, because after a really long spell of no seizure, one day I just, in my sleep, I got a seizure and I didn't know. And I've had that a few times in my life. So there are different aspects of it, but I just want to say that we need to bring awareness and humanization to it, that you can still have a normal life. I work, I enjoy swimming. That's one of the things I do, enjoy doing. I drive. So you just really need to know your case. And then I have my neurologist here that I report to. I'm on medication. But yeah, I think it's really good to bring that awareness, because a lot of kids, I can't imagine the amount of kids going through that petit mal, because for the petit mal seizure, you just absent seizure, you just blank out. You know, if people don't know what's wrong with you, you can start speaking gibberish, and then they assume it's a demon in you, and that can have a whole bunch of, you know, unintended, you know, consequences, you know, as a young person growing up, you know. And so I'm really glad that we have a forum like this, a platform like this, where people can learn about, you know, the realities of this, and that you can live a really normal life. You just need to be well educated and aware of your situation. So thank you.
Thank you very much, Shitu. Prof, you want to say anything on that before I make any comment?
No, it's a good experience. I don't remember. I said I made diagnosed in a Royal Free Hospital.
Yes, I remember you. I've got the letter.
Well, that's good.
Yeah.
That's good. I'm glad that you've got a very good outcome, and you know, you've adapted well, and you're doing very well. So that's good. That's the outcome we want everybody to have. You know, people that will get epilepsy, that they accept it and they know their limitations, they know what they can do and they know what they cannot do, and they live as normal a life as possible. Congratulations.
Yeah.
One thing I want to say to this, I want to pay special homage to him. Forget the courage for come on and say something, because like this, we try for make their situation in a salon be a normal, where if somebody they go through something, let able say if you want to say not by force, but if you want to see them, let them feel comfortable for able to see them without people not see them and judge them. So thank you very, very much for sharing your story with me. And I believe see people can go look at this and hear this and feel inspired, and hopefully the attitude in our community will change towards not just epilepsy but other illnesses that we'll get. Well, thank you very much on that. One of the last thing I will say, oh, there's more questions. Okay, somebody asked, this obviously now I would say that's something waiting at the street and say what we call jamba marijuana. So man say the oil will help for manage or cure How true is that?
Well, no, I don't know about the oil, but sadly cannabis, they don't find out say useful for some form of epilepsy, particularly certain epilepsy they affect picking them when a very, very bad outcome epilepsy where they can get at a very early age. They don't find out say cannabis can help them picking them more than a lot of the established drugs that we then get. But a lot of countries they still not, they not adopt that practice there yet. And I remember in England a couple of years ago, where somebody go to America, bring cannabis come for him picking. There was a hoo-ha, they arrest them and all that. So we still have a long way to go, but the main thing is that there is a potential that cannabis can help, but not to the way we know cannabis in terms of smoke or for rub the oil, but I think it's more medicinal. And we'll see how it goes, but there's a possibility that it might work.
Yeah, so there's more research required. So you see, and the last two I will take, somebody say upline. This is not something a question we people ask in the past as well. See, most of the thing they do not tongue. I'm glad they would make a lot of progress because when maybe they grow up and stuff, some of them not be available. But now more and more and more, they find out say more and more things they get done, which I'm really, really proud and happy about. However, how will they manage the one way they upline? Somebody they say in a doctor and they can go now the the upline places them and stuff. And when they see anybody with the upline, they on any kind of medication for epilepsy. So waiting at the plan for them people in there.
Well, it depends also upline you go, because we get several clinics. We get over 8 or more clinics upline, and we supply the medication and then get patients the way they go. So yes, the outreach is not as good as we want it because we just not get the funding for manpower for the go to the villages. So basically we depend on the patient and for come between the towns and mostly the main district headquarters and chiefdom headquarters, now they we get clinics them. So patient then get for come meet we rather than we go meet them. So we know they reach as many people as we should, but there are clinics there and there are drugs available because we supply them. But we need to do a lot more, and we need a lot more support for get more people and for get involved.
Okay, so one thing I'll go for ask as well, after the show, I'll go for ask if there's any program on the one where on I want to train more people them, whether on a free tongue on upline, and also the various parts the way when I get the units there. You go finally get them and also add them for the video they put on our Facebook and YouTube. So if somebody they whether interested for help financially or somebody they want to be part of our effort and maybe want to get trained for able help as a HC or something like that. Or maybe somebody they suffer from and want to get to now for ask for help. They go find for that information, they be available. So I go reach out, please. Let me see. What's the last? Somebody say if hormonal changes they affect the frequency of epilepsy episodes.
Yes, you get what you call a big word, catamenial epilepsy. In other words, so women them just around the period time, not any them can get more seizures. So yes, hormones then can affect the timing and the frequency of the seizures them. Again, pregnancy can also make a difference in when women are pregnant because of the change in hormone. It can also affect them the seizure frequencies. Then yes, so hormone does affect the frequency.
Thank you very, very much. Me family them. I know some of them enjoy this. There's a lot more questions they want to get. I don't try for read. I think I don't get all the questions they want to ask. I don't try for ask them all. For people who they ask, say this now one silent killer, also diabetes, we don't do diabetes before as well. And if I don't share the YouTube channel, I will try for we share them again for the if you want to see the previous session that we don't do, please feel free. But every good thing must come to an end. Professor, I thank you so very, 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 very much. I enjoyed the session. I don't learn a lot. I feel I learned previously, but trust me, it's like say you do 2 sessions. The first one I'm just the preliminary stuff. This one I enjoy. I'm superb. But thank you very, very much. What I can do now, and I go around the panel of the other doctors then for let them give a few words. Then I will come back to you. Let's just give Fambo them one last word with a message for take home. Then we will finish for today. So I will start with Dr. Bell. Dr. Bell.
Yes, Professor Lisk, thank you very much for this session. It was a really, really good session. I mean, we learned a lot. I'm not going to anything for add to that, to what you don't say, and for just make people get the awareness and say it's very important for make the health sector develop alone. Through policies, through change of attitude among doctors, among nurses. I mean, this one, we want border where they tell you what salons and nurse tell and so. I mean, and also sometimes when some people they not get things for say, they can just talk some rampant things. And so actually, it's to say even professional doctors, nurses, they give false information, and that's really, 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 really bad. And also to religious leaders them as well, and we traditional healers them as well. And I hope say some of them are going to forget this message here. So and no say there is a place where they can for care people and go for make them go treat them, because it is treatable. Be actually able for support people then. So Professor, thank you very much, and we thank all my way come and we listen to this message, and please do not spread the message, yeah, because well body better pass gently.
Thank you very much, Dr. Bell. Dr. Kamara, I don't know, you say you did drive. I don't know if they're in a position for say something.
I don't know. I might go off at any time. Can you hear me?
Yes, we hear you.
Right. So, I tell you, Prof, I think I can echo TM in sentiment in that 2 session. I'm so pleased, and I can't thank you enough, sir. Now, there's one thing where you say we're actually really, really impressive, that no one take braid come on at the one day way now the traditional healers come on at the mouth. So it's like a collaborative. So when I treat what you able to tire when I know for do when I send it to me. That is absolutely vital, because it just shows that there is that, you take off that divide, because if they feel threatened, then that's why this thing they continue. But if they know so they're supported, I think so we could go a long way, especially now that we know say the awareness is there. People that know say this one or two double this story, this particular topic, very close to me. I lost my uncle to this, and I know exactly how I feel having gone through medical school, like I've been tell Prof last week. All the cultural and traditional myths where they attached to this thing is just phenomenal. And I'm glad to say we're able to debunk them here, for demystify them, and actually for little people and benefit from them. I've been just the hope say we forget the political, might for day with we today, make the year say the need for take this thing and categorize them as a NCD, non-communicable disease, which is absolutely vital. If they give GDP division, they need for include epilepsy. Now that's the message that I hope say we could pass on to the MOH. So thank you so much, Prof. But as I say, anybody where they are longer, where they are around we, if they no say, then get any connection, by all means, please, that this we need for do for we people them. But remember, spread the word, because what you do, well body, better pass gentry. Thank you so much, Prof, and everybody else.
Thank you very much, Dr. Kamara. Prof, over to you, sir. One last word for people them for take home. With a take home message for them, sir.
Well, the take home message is that Epilepsy Day and we get for change our attitude in terms of the way we look at epilepsy. Because we can talk now so and discuss, but them are within our village. We don't reach them. Them are within our village where person begin for them. It no say for care in picking a clinic rather than for care and go to traditional healer. So the outreach, the sensitization, the awareness raising is the main part of the program where we try to do, but all this needs money. We've been to every chiefdom in Sierra Leone. I've been to every province in Sierra Leone, all 14. We don't go there, we don't get seminars, we don't see people there. But it costs money. What would they take with team for golden place? Then you get to have vehicle, fuel, hotel bill. It's expensive. And right now, we don't have the funds for continue for do the outreach visits and then train because anytime we go there we get a seminar, we call all the health workers, then we train them for recognize and for know how for refer. So we are working on a lot of constraints right now because of lack of funding. So they want to get influence. If there's any way they can help, for the program, then we will appreciate them because it means that we can continue and we can able to reach more people then. But I thank you very much for giving me the opportunity, at least for make us share my experience with you. Thank you very much.
Very much, sir. Now we for thank you for taking your time, and your resource and everything for kind of dedicate this to you people them. So we people them, they will all benefit. Like I say, I don't learn a lot. The family and plenty thank you. When I don't be very, very patient, when I don't be very professional, when I don't listen to all this, I hope see when I don't learn, please do and I pass the word. For let other people then learn from what you yourself don't can see today. It's not just about attending live because attending restriction can they wait to make person not able to attend, but when I pass the message, let people then visit the YouTube and Facebook page, let them learn from session they will be done past before. If I feel say we need to go over any other program, we will be done do before or a new one, and I'll let we know. Till we meet again, well, body better pass gently. We go there offline until the Lent and Ramadan season finish because people then they really we get for fast for both Christians and Muslims. But once the Ramadan and Lent period finish, we go return, we go send message out. We don't share the WhatsApp group link before, so feel free for join. But till we meet again, well, buddy, better pass gently. Good night.